What if everything your doctor told you about blood pressure after 60 is completely wrong? What if the number they have been medicating you for is actually normal for your age? What if lowering it is quietly making you sicker? Stay with me, because in the next few minutes, I am going to share something that could change how you manage your health forever. I am talking about blood pressure after 60, and I want to be direct with you right now. The guidelines most doctors use were written for younger adults, not for your aging body, not for your arteries, not for your brain, and yet millions of people over 60 are being scared into aggressive treatment based on numbers that may not even apply to them. I am not telling you to stop your medication. Please do not do that without your doctor. What I am giving you today is the full picture, the one most doctors do not have time to give you in a 7-minute appointment. By the end of this video, you will understand what blood pressure actually does after 60. You will understand why 120/80 may be completely wrong for you. You will know what the research actually says, and you will know exactly what to do today to protect your heart and your brain. This is the conversation your doctor should be having with you. Let us get into it. Point number 1, what blood pressure actually is and why your arteries after 60 are fundamentally different. Most people think blood pressure is just a number. 120/80 good, 140/90 bad. Take a pill. Done. But that oversimplification is causing real harm to real people every single day. Your heart is a pump. Every time it beats, it pushes blood into your arteries. That push creates pressure. The top number measures that push. The bottom number measures the pressure when your heart rests between beats. Your body needs that pressure. Without it, your organs starve. Your brain stops working properly. Pressure is not the enemy, it is the delivery system. Now here is where everything changes after 60. When you are young, your arteries are elastic, flexible like new rubber tubing. They stretch with every heartbeat and bounce back. That elasticity absorbs pressure and keeps numbers low. The system is efficient and beautiful. But by the time you reach 60 or 65 or 70, your arteries are no longer rubber bands. Decades of use have changed them. Calcium has deposited in the walls. Stiff collagen has replaced flexible fibers. Your arteries have become more like rigid pipes than flexible tubes. And what happens when your heart pushes blood through rigid pipes? Pressure goes up, naturally, physiologically, as a direct consequence of aging itself. This is called arterial stiffness. And the blood pressure rise it causes is not the same thing as hypertension in a 35-year-old. The mechanism is different, the risk profile is different, and the ideal treatment should be different. But for decades, we have used the same number for everyone. There is also a concept called the J-curve. Studies show that the relationship between blood pressure and mortality is not a straight line, where lower is always safer. The curve dips as pressure falls from dangerously high levels, but then it curves back upward at very low pressures. Too low is also dangerous, and in older adults, the bottom of that curve sits higher than in younger people. Here is the myth. High blood pressure always means your heart is working dangerously hard, and you must push it down as far as possible. Here is the fact. After 60, a higher systolic reading often reflects your body compensating for stiff arteries. Forcing it down too aggressively can starve your brain and organs of the blood flow they need. Actionable tip: start paying attention to both numbers separately. If your systolic is elevated, but your diastolic is normal or low, this pattern is very common after 60. It is called isolated systolic hypertension. Ask your doctor specifically whether your pattern is consistent with arterial stiffening and what the appropriate target is for your age and your pattern. That question alone will start a very different conversation. Point number 2, the 120/80 myth and where this number actually came from. Most people assume the 120/80 target was built on decades of research in older adults. They assume it represents settled universal biological truth. That is not what happened. The early landmark research on blood pressure was conducted mostly in middle-aged adults, people in their 30s, 40s, and early 50s. The Framingham Heart Study, which shaped blood pressure medicine for generations, enrolled participants well below 65. The evidence that very high blood pressure is dangerous came largely from younger populations. And then something happened that changed everything without the evidence to back it up: the extrapolation. The assumption that whatever target was right for a 45-year-old must also be right for a 75-year-old. Same number, same medication, same urgency for everyone. Then came the HIVET trial, the hypertension in the very elderly trial. This was the first large randomized trial to look specifically at adults aged 80 and over. And what it found was important. Treating very high blood pressure in this age group did reduce stroke risk. But the target actually achieved in the treatment group was around 144/77, not 120/80. A systolic of 144 was sufficient to provide meaningful benefit in the very old. Then came SPRINT in 2015. This was the study that changed guidelines everywhere. It suggested targeting below 120 systolic was better than targeting below 140. The headlines exploded. Lower is better. Push the number down. And in 2018, American guidelines lowered the hypertension threshold from 140 to 130. Overnight, millions of people who had been told they were fine were reclassified as having high blood pressure. But here is what the headlines missed entirely. Sprint excluded people with diabetes. It excluded people with prior stroke. It excluded those with significant kidney disease or heart failure. These are not rare conditions in adults over 60. These are extremely common conditions. The typical older adult walking into a primary care office looks nothing like the carefully selected Sprint population. More importantly, the way blood pressure was measured in Sprint was completely different from how it is measured in your doctor's office. In Sprint, participants sat alone in a quiet room for 5 minutes. No clinician present. An automated device took multiple readings and averaged them. No white coat effect. No anxiety. When researchers analyzed what those Sprint readings would have corresponded to in a standard office setting, they found the Sprint intensive target of 120 was equivalent to roughly 133 to 135 in a real-world clinical measurement. The comparison was not apples to apples, and the aggressive lower is better narrative was built on that flawed comparison. The European Society of Cardiology reviewed the exact same data. They did not agree with the American conclusions. They kept their threshold at 140. Canadian guidelines kept 140. Australian guidelines stayed at 140 to 150 for older adults. When the world's leading cardiology organizations look at the same evidence and reach different conclusions, that is not a minor footnote. That is a sign the evidence is not as clear as any single guideline suggests. Here is the myth. The 2018 American guidelines represent a clear universal scientific consensus that everyone over 60 should target below 130. Here is the fact. Major international cardiology bodies disagree by 10 to 20 millimeters of mercury on what the right target is for older adults. That disagreement is the difference between one medication, two medications, or no medication for millions of patients. Actionable tip. When your blood pressure is measured, ask to sit quietly for 5 minutes before the reading. Ask for 2 readings to be taken and averaged. Ask for measurements in both arms. And if your doctor is making major treatment decisions based on a single reading taken during a rushed, anxious appointment, ask whether home monitoring data could be used instead. A 2-week average of home readings is far more accurate than any single office measurement. Point number 3. The brain connection and why pushing blood pressure too low after 60 can speed up cognitive decline. This is the point that concerns me most. And it is the one that receives the least attention in mainstream medical conversations, despite having some of the most alarming evidence behind it. Your brain is the most blood-hungry organ in your body. It is about 2% of your body weight, but it consumes 20% of your total blood flow every moment of every day. It is running constantly, and it is extraordinarily sensitive to even small reductions in blood supply. Your brain has its own pressure regulation system called cerebral autoregulation. This system adjusts the diameter of brain blood vessels to maintain stable blood flow across a range of systemic blood pressures. When blood pressure drops, the brain dilates its vessels to compensate. When blood pressure rises, it constricts them. It is a remarkable protection mechanism. But here's the critical truth about aging. Cerebral autoregulation becomes less efficient as you get older. The range over which it can successfully compensate narrows. And the lower threshold, the minimum blood pressure at which your brain can still maintain adequate flow, shifts upward with age. What this means practically is genuinely disturbing. A blood pressure of 110 over 65 might be completely harmless in a 40-year-old. At that pressure, a young brain's autoregulation easily maintains excellent flow. But in a 74-year-old with stiffened arteries and impaired cerebral autoregulation, the same blood pressure may represent chronic brain underperfusion. The brain is not getting the blood it needs. When that happens, the consequences accumulate quietly and invisibly. Brain fog, persistent fatigue, difficulty concentrating, impaired memory, slowed processing speed, and accelerated structural changes in brain tissue associated with dementia risk. Research published in JAMA Internal Medicine followed older adults with mild cognitive impairment and examined what happened when their blood pressure was treated to different targets. Those treated to lower targets experienced faster cognitive decline and greater brain atrophy compared to those kept at more moderate levels. Research from the Leiden 85+ study in the Netherlands found something that completely inverts the standard narrative. In very elderly adults, higher blood pressure was associated with better cognitive performance. Not worse. Better. The people with somewhat higher blood pressure were cognitively sharper. A systematic review published in Circulation found that in adults over 75, low diastolic pressure below 60 to 65 was independently associated with increased dementia risk. The medication intended to protect your brain may, in some older adults, be increasing the risk of losing cognitive function. There is also orthostatic hypotension. This is a sudden drop in blood pressure when you stand up, when your resting pressure is already suppressed by medication and your autonomic reflexes have slowed with age. This compensation can fail when you rise. Blood pressure drops sharply. Flow to your brain momentarily decreases. You get dizzy, you lose your footing, you fall. Falls in older adults are not minor events. A hip fracture in a 75-year-old carries a 1-year mortality rate of 20 to 30%. Head injuries from falls can cause irreversible brain damage, and the fear following a fall frequently triggers a cascade of reduced mobility and progressive deconditioning that permanently reduces quality of life. Here is the myth. Lower blood pressure is always better for your brain, and getting your numbers as low as possible is the most brain protective strategy. Here is the fact. For adults over 65, maintaining blood pressure adequate to sustain cerebral blood flow is just as important as preventing it from going too high. Too low is a real danger for the aging brain, not a theoretical one. Actionable tip. Pay close attention to how you feel when you change position. Every time you move from lying to sitting or sitting to standing, notice whether you feel dizzy, lightheaded, or suddenly unsteady. If this is happening even occasionally, it is clinically important. Keep a simple log of when it happens. Bring it to your doctor. Ask specifically for orthostatic blood pressure measurement. Blood pressure checked lying down and then standing. This simple test is standard in geriatric medicine, but frequently skipped in routine primary care. Point number 4. The medications and the side effects nobody is telling you about clearly enough. If you are over 60 and your blood pressure is elevated, there is a high probability you are either on medication or being pushed to start one. You deserve to understand clearly what these drugs do and do not do, and what they can do to your body and your quality of life. Where blood pressure medications genuinely earn their evidence is at the high end. For people with consistently elevated systolic above 160, antihypertensive drugs provide real, meaningful, documented reduction in stroke and heart failure risk. That evidence is solid. If your pressure is genuinely very high, medication saves lives, and I will never minimize that. But the evidence for benefit thins considerably as we move toward moderate elevations. And the side effect burden in older adults is real, substantial, and frequently unacknowledged. ACE inhibitors like lisinopril and ramipril cause a dry, persistent cough in 10 to 20% of patients, 1 in 5 to 1 in 10 people. This cough disrupts sleep. It can persist for months after stopping the drug. It is frequently misdiagnosed as a respiratory condition and treated with additional medications. Diuretics cause your kidneys to excrete more fluid, lowering blood pressure, but they also deplete potassium and magnesium. Low potassium causes muscle weakness, cramping, and dangerous heart rhythm abnormalities. Diuretics also cause frequent nighttime urination. For an older adult, multiple trips to the bathroom in the dark every night means multiple fall opportunities every night. Beta blockers cause profound fatigue in many patients, not mild tiredness. The kind of fatigue that makes daily life feel burdensome and that can be indistinguishable from depression. They also cause sexual dysfunction, cold extremities, and they blunt the cardiovascular response to exercise. If regular physical activity is one of the most powerful longevity interventions available to you, and it absolutely is, a medication that makes exercise significantly harder is working against your health. Calcium channel blockers commonly cause ankle swelling. This swelling is frequently misread as a new condition and treated with a diuretic, which causes its own side effects, which triggers another prescription. This is what geriatric medicine calls a prescribing cascade. One drug causes a side effect. The side effect is treated with another drug. That drug causes another side effect. Before long, you are on 5 medications when you started with 1. Here is what makes this worse. When older adults on blood pressure medication develop fatigue, brain fog, dizziness, or a general sense of feeling worse than before, their doctors frequently attribute these symptoms to aging, not to the drugs. Additional medications get prescribed to treat what are actually drug side effects. The cascade deepens. There is a formal evidence-based concept called deprescribing. The supervised reduction or discontinuation of medications that are no longer providing net benefit. Multiple clinical trials have shown that carefully supervised deprescribing of antihypertensives in stable older adults results in improved quality of life, reduced falls, better cognitive function, and in some studies, reduced mortality. Deprescribing is not abandoning treatment. It is precision medicine applied honestly. Here is the myth. Once you start a blood pressure medication, you need it forever, and reducing it is inherently dangerous. Here is the fact. For many older adults who have made lifestyle changes or who are experiencing significant side effects, blood pressure medications can sometimes be safely reduced or discontinued under careful medical supervision. And for some people who are currently over-medicated, relative to what the evidence supports, this process may genuinely improve both the length and quality of their life. Actionable tip. Ask your doctor for a comprehensive medication review. For each blood pressure drug, ask these questions. What is the evidence that someone my age with my conditions benefits from this medication at this dose? What are the recognized risks if my pressure goes below the target? Are any of my current symptoms possibly caused by this medication? And given my lifestyle changes, is there any basis for discussing a supervised reduction in dose? Point number 5. What the evidence actually says about the right blood pressure target after 60. Let me give you a clear, honest, evidence-anchored picture of where the science actually stands. There is genuine consensus at the extreme end. Almost every major guideline agrees that consistently elevated systolic above 160 warrants treatment in adults over 60. The evidence for stroke prevention at these levels is strong and consistent. Very high blood pressure is genuinely dangerous at any age. On this point, the disagreement is small. The real controversy lives between 130 and 160 systolic, and this is where most older adults find themselves. American guidelines say treat above 130. European guidelines say treat above 140 for most adults. Canadian guidelines say 140. Multiple other countries say 140 to 150 for older adults specifically. This is a genuine substantive disagreement between the world's leading cardiology authorities spanning 10 to 20 millimeters of mercury. That gap is the difference between medication and no medication for enormous numbers of people. For adults over 70 or 75, the evidence that targeting below 130 provides additional benefit over targeting 140 to 150 is weak to non-existent. And the evidence that pushing below 130 in this age group causes harm through falls, kidney injury, and cognitive decline is growing steadily. The concept gaining traction in geriatric cardiology is individualized blood pressure targeting. Rather than one number for every person over 60, we assess the individual. How old are they biologically, not just chronologically? Do they have arterial stiffness, any cognitive impairment, a history of falls, autonomic dysfunction, significant kidney disease? What is their frailty level? What medications are they already on? A 67-year-old who exercises regularly, has no cognitive symptoms, no fall history, and whose systolic of 148 reflects arterial stiffening is a completely different clinical picture from a 67-year-old who is sedentary, has early cognitive complaints, has fallen twice in the past year, and has the same blood pressure reading. Treating them identically is not precision medicine. It is crude pattern matching. Several geriatric medicine organizations now explicitly state that for frail older adults, those over 75 to 80, and those with cognitive impairment or orthostatic hypotension, a systolic target between 140 and 150 may be appropriate and even optimal, rather than a failure of treatment. Here is the myth. There is a settled, universally agreed, scientific blood pressure target for people over 60, and your doctor is following it faithfully. Here is the fact. Major international cardiology bodies disagree significantly on the right target. There is no universal consensus. And the emerging evidence increasingly supports individualized assessment over universal numeric thresholds. Actionable tip. Buy a validated upper arm home blood pressure monitor, not a wrist device. Measure twice daily for 2 consecutive weeks. Morning before medication after 5 quiet minutes, evening again after 5 quiet minutes. 2 readings each time averaged. Record everything. At the end of 2 weeks, calculate your average. Bring that log to your doctor. Multiple home readings over weeks are substantially more accurate than any single office measurement. They eliminate white coat hypertension, which affects 15 to 30% of patients. They reveal patterns that a single reading completely misses, and they give your doctor real data to work with. Point number 6, the lifestyle interventions that actually work and that you can start today. Here is the genuinely good news. There are lifestyle interventions with powerful evidence behind them for blood pressure management in older adults. Evidence from large, rigorous clinical trials. Interventions that in many cases produce reductions comparable to medication, with no side effects, no prescriptions, and with benefits across every organ system simultaneously. Dietary sodium reduction is one of the most powerful. Older adults are significantly more salt-sensitive than younger people due to age-related changes in kidney function and hormonal regulation. Large randomized trials show that meaningful sodium reduction lowers systolic blood pressure by 5 to 7 millimeters on average in people with hypertension. In highly salt-sensitive older adults, the reduction can reach 10 to 15 millimeters, larger than many single medications achieve. The practical reality is that only 10 to 15% of dietary sodium comes from the salt shaker. The vast majority comes from processed foods, canned goods, bread, restaurant meals, deli meats, and cheese. Label reading and whole food substitution are where the real impact lies. The DASH diet is one of the most rigorously studied dietary interventions in cardiovascular medicine. Fruits, vegetables, whole grains, lean protein, and low-fat dairy, limiting saturated fat, red meat, and sodium. Studies consistently show DASH reduces systolic blood pressure by 8 to 11 millimeters. Combined with sodium reduction, the total effect averages 11 to 16 millimeters, comparable to a first-line blood pressure medication. With no prescription required, exercise stands as perhaps the single most powerful intervention for both blood pressure and overall longevity in older adults. Regular aerobic exercise, brisk walking, cycling, swimming, produces resting blood pressure reductions of 4 to 9 millimeters in hypertensive individuals. Unless blood pressure is at extreme levels above 180 moderate intensity, exercise is safe and actively recommended for hypertensive older adults. The brief rise in blood pressure during exercise is normal physiology, not danger, and the sustained reduction over weeks and months is real and medically significant. Resistance training provides additional independent blood pressure benefit. Trials show systolic reductions of 3 to 6 millimeters additive to aerobic exercise. Combined with the benefits for muscle mass, bone density, and fall prevention, resistance training is doubly valuable for older adults. Sleep quality is an underappreciated driver of blood pressure that is frequently missed. Obstructive sleep apnea causes repeated blood pressure surges throughout the night, keeping the autonomic nervous system chronically activated. It is dramatically underdiagnosed in older adults. Treating sleep apnea with CPAP therapy produces blood pressure reductions of 5 to 10 millimeters, comparable to adding a medication. With the additional benefits of better sleep, better cognition, and better energy, if you snore loudly, wake unrefreshed, or your partner has noticed you stopping breathing during sleep, please ask your doctor for a sleep study. This could be the most important diagnostic step you take for your blood pressure. Here is the myth. Lifestyle changes only matter for mildly elevated blood pressure and become irrelevant once medication is started. Here is the fact. Rigorous lifestyle intervention produces clinically substantial blood pressure reductions at every level of severity. It works as an adjunct to medication, allowing dose reductions in many cases, and it provides benefits through mechanisms that no medication can replicate. Actionable tip: track your sodium for 7 days. Just observe. Log everything you eat using any free nutrition app and watch the sodium numbers accumulate. Do not change anything yet. Just watch. Most people discover they are consuming 3,500 to 5,000 milligrams daily when they believed they were being careful. Seeing the reality clearly is the catalyst for change. Once you see it, you know exactly where to act. Point number 7, the conversation you need to have with your doctor and exactly what to say. Everything in this video means nothing without action, and the most important action is showing up to your next medical appointment as an engaged, informed partner, rather than a passive recipient of whatever is decided for you. Here is the language I want you to use. Start here. Doctor, can you explain why the specific blood pressure target you are recommending is the right one for someone my age with my health history? I understand that guidelines differ between major international cardiology organizations and that the evidence in older adults specifically is more nuanced. I want to understand the basis for the target we are pursuing, then ask about measurement. I have brought a 2-week log of home blood pressure readings taken twice daily. Can we use this data as the primary basis for our treatment decisions today, rather than a single office measurement? Then ask about the lower bound. I have read about the J-curve phenomenon suggesting that blood pressure can also be too low in older adults with real consequences for cognition and cardiovascular health. Is there a lower threshold we should be monitoring to ensure I stay above it? Then ask about orthostatic hypotension. Can we check my blood pressure both sitting and standing today? I want to know whether I am experiencing significant positional drops, especially since I am taking antihypertensive medication. Then ask about deprescribing. I have made meaningful lifestyle changes, including dietary modifications and regular exercise. Is there a basis for discussing whether my current medication dose remains appropriate for my situation right now? And if you have symptoms? I have been experiencing fatigue and occasional dizziness since starting this medication. Could these symptoms be related to my treatment? What would be the approach for determining whether a dose reduction might relieve them while maintaining adequate control? These are not confrontational questions. They are not distrustful. They are the questions of a patient who understands that medication management is not a set-and-forget process, but an ongoing assessment that must evolve as your body and circumstances change. Your experience matters. How you feel on your current treatment is clinically valid data. Fatigue, brain fog, unsteadiness, reduced sharpness, these are not simply aging. They may be side effects of treatment that deserves reassessment. The number on the cuff is one data point. How you function every day is equally important medical information. Here is the myth. Passively accepting your doctor's recommendations is the safest and most respectful approach to managing your health. Here is the fact. Patients who actively engage, who ask questions, who track their own data, who participate in shared decision-making consistently have better clinical outcomes, fewer adverse events, and better quality of life. Engagement is not disrespect, it is ascension. Here is your one action to take today. Buy a validated upper arm home blood pressure monitor, $20 to $30. Commit to measuring twice daily for 2 weeks, morning before medications after 5 quiet minutes, evening the same, 2 readings each time averaged and recorded. At the end of 2 weeks, you will have something genuinely valuable, a real accurate representative picture of your blood pressure in your actual life.